Hello, everybody. It's a great session we just heard on renal denervation, and we're now going to shift gears and talk about calcified coronary disease, which continues to be one of the most demanding challenges we face in the cath lab. The tools and the strategies available to us are evolving rapidly, and this session is all about practical image-guided approaches to vessel preparation that can make a real difference in outcomes. I'm joined by an exceptional group of friends and colleagues. We have Ziad Ali, also from New York, David Reisig from Scottsdale, Robert Riley, who's from Bellevue, Washington, and Margaret McIntaggart, who's abroad but was kind enough to record a presentation for us in advance. Please keep your questions coming through the Q&A. We'll try to get to those in the ample time we have for discussion throughout the panel. And I think we'll just kick it right off with the talk from Ziad, who's going to tell us a little bit about how imaging and calcium modification strategy interact. Pretty much nobody better to give us this talk, and so I'm really looking forward to it. So Z, and over to you.
Thanks very much, Ajay, for inviting me to participate in this. It's been about a decade in the making to get this to where we are. So let's start off with how you can detect calcified lesions. So probably the most common way that we do this outside the cath lab is with a calcium score, or with now more commonly a coronary CT, which is a very sensitive test. In fact, because of the partial volume averaging, you can actually see calcium with extreme sensitivity, maybe at the cost of specificity. Most of us are used to looking at coronary calcium on the angiogram. It's very specific, but it's not very sensitive. You are going to miss about 40% of calcium because of its angulation, because of its location, and because of the projection of the angiogram. And both IVUS and OCT, which are intravascular imaging tools, are both highly sensitive and specific. And I mentioned that IVUS might be oversensitive, just like coronary CT, and we'll talk about a little bit later on why. So let's take this case. Okay, so here's a patient with very moderate lesion in the right coronary artery. Most of us might not even consider doing anything to this. There's very mild calcification on the angiogram, but the CT actually shows a calcium along with this sort of a hypoattenuated plaque in that area, which gives you perhaps some area to concern for physiological significance. And so what we go ahead and do is we perform IVUS on this lesion to make sure that we're not missing anything, because the angiogram can lie. And we pick up the fact that there's areas of 270 degrees of calcification in this tight lesion, or maybe not tight lesion. And then we perform OCT, and we get probably all of the details what we need. And so what you can see here is that actually the calcium, despite its arc, is actually very, very thin. And so this is critical for us to understand that it's not only one parameter, such as the presence or absence of calcium, but actually it's a culmination of factors that help us decide how important calcium is to our case. So traditionally, what you're going to see from the data is that we define moderate calcium as 180 to 270 degrees on a single cross-section, and severe at more than 270 degrees. And as I mentioned to you before, compared to IVUS, the angiogram is relatively insensitive, but it is very specific. And we start to see calcium on the angiogram that we can detect by IVUS when it gets to about 110 degrees. And one of the very important things that's probably overlooked on IVUS is understanding the physics principles of the IVUS, which of course is ultrasound. And as you can see on this 0.5 millimeter per second pullback, what you see is this sawtooth pattern of the sound penetrating into the wall. But a very good way to determine whether or not you're calcified is to see whether you have signal dropout on the longitudinal pullback. And here you can see areas which have severe calcification, because you have complete signal dropout, and this sawtooth pattern is lost, and it's on both sides of the artery. When we have OCT, it's actually the same parameters that we use, moderate 180 to 270 and severe greater than 270. You'll also notice that compared to the angiogram, compared to OCT, the angiogram is not very sensitive. We start to pick up calcium on OCT when it gets to 100 degrees on OCT on the angiogram, when it gets to be 4 millimeters long and 0.5 millimeter thick. And that's very important. And we're going to talk about that a little bit more in detail. It's a little harder to see calcium on the longitudinal because you can't see those completely sharply demarcated borders like you can on the cross section, that characteristic cookie cutter type appearance. But of course, one of the great things about OCT, which IVUS is lacking, is the implementation of artificial intelligence, where artificial intelligence highlights for us with parameters that we choose, for example, in this case, greater than 180 degrees of calcium, here 270, exactly where the calcification is along the longitudinal pullback. So these are some of the tools that we can use. I showed you CT, I showed you the angiogram and the relative benefits of maybe IVUS and OCT. But the question is, why do you need the intravascular imaging? And the reason is, of course, the angiogram is the gatekeeper. So if we see the calcium on the angiogram, which happens in about 40% of patients, we know that it's there. But if you image these same patients that are undergoing angiography, you actually double the sensitivity or double the number of patients that you pick up the calcium. So IVI clearly improves the sensitivity. So let's just take a second and understand that from the angiogram, only angiographic severe calcium, which means calcium on both sides of the artery, is related to stent under expansion, not none, mild, or moderate. And so let's talk about why that ends up being important. That ends up being important because there are parameters on intravascular imaging more than simply the arc of 270 or 180 that impact stent expansion. And in this model, what you can see, which we use called calc, when you have calcium that's circumferential, when you have an arc of calcium with a length of greater than 270, that's 5 millimeters, if you have a calcified nodule, or if your vessel is less than 3.5 millimeters because of Laplace's law, when you have two or more of these features, you're more likely to get stent under expansion. Now, of course, this is not tied to a clinical outcome, but it is tied to stent under expansion, which is subsequently tied to a clinical outcome. So this is an important slide because it's telling you it's not just the circumference, which was largely made for us to increase enrollment in clinical trials. It's a number of intravascular imaging features that predict stent under expansion. And this is also the case for OCT. So when we look at OCT, we see that when the arc is greater than 360 degrees or 360 degrees, when the minimum calcium thickness is greater than 0.3 millimeters, and when the calcium length is 3 millimeters and the arc is 3/4 of the vessel, then we end up with predictors for stent under expansion. And we like to call this the rule of threes because it's 360 degrees, minimum arc of 0.3 millimeters, 3 millimeters long with 3/4 of the vessel arc. And if you have more than two of these, together, these again predict stent under expansion. And so the reason this is important is you can pick up the calcium on the angiogram, but it won't tell you the morphology. And the morphology of the calcium actually determines the proper lesion preparation. So for example, if you have concentric calcium, basically everything works. NC balloons are going to work, specialty balloons will work, atherectomy will work, IVL will work. But when you start to move into more nuanced calcium morphologies, such as eccentric calcium, nodular calcium, or deep or thick cap calcium, then you start to have to pick your tool for modification based on the imaging rather than simply based on the angiogram where you're going to be guessing. And so what we're ultimately trying to achieve by any of these lesion preparations is to identify calcium fracture. And here's an example of calcium fracture by IVUS in two different cross sections. And here's an example more easily identified of calcium fracture on OCT in multiple projections. Now, let's talk about this important registry that was published some years ago. In this very interesting registry of almost 6,000 patients of complex PCI, what you'll notice is that out of all the risk factors, the only complex lesions that didn't benefit from intravascular imaging guidance in practice were in-stent restenotic lesions and calcified lesions. So that kind of left me scratching my head because why is it that in practice, these two very common risk factors don't lead to a benefit when we sort of have the anecdotes that we do? And the reason is because we know that there's a benefit now to an algorithmic approach. Now, there's lots of algorithms. There's the New York City subway, there's the London tube map, there's probably one for Paris. It is important to follow an algorithmic approach. And so let's see about why that is. Here's the first sort of big, large-scale randomized controlled trial to show a benefit for intravascular imaging guidance versus angiography. And what you'll notice is when you apply an algorithmic approach in this subgroup analysis of the Renovate PCI study, they have a very strong trend towards an improvement in severely calcified lesions. And very interestingly, when we did the same analysis, you find an almost identical pattern of in severe calcification in Illumian 4. And so in these two very large randomized controlled trials with algorithmic approaches comparing intravascular imaging to angiography, you can see that out of all the subgroups, the one that tended to get the greatest benefit were those patients with severe calcification. And so in Illumian 4, when we looked at this in greater detail, what we realized and learned is that in almost 1,000 patients, which is the largest sub-study of patients ever performed, comparing severe calcification of imaging guidance versus non-imaging guidance, not only do you get a larger lumen area, but you also significantly improve target vessel failure by almost 40% at 2 years. And you'll notice that the curves continue to separate. It's not just a benefit that happens early, like is happening in many trials at the moment, for example, in some drug-coated balloons. And so when we performed a meta-analysis of these angiographic versus IVI-guided PCI in calcified lesions, we found this trend to be consistent. Ultimate, Renovate Complex PCI, Illumian 4, and October, all of them showed a favor for intravascular imaging guidance. So in conclusion, calcium shouldn't be treated as an imaging-defined phenotype. It's not an angiographic impression. We should detect and phenotype it. The angiogram is the gatekeeper, but IVUS and OCT define the calcium features, which help us decide which tools to treat. Score the burden. Don't just look at a single parameter. Don't just look at the arc of 270 degrees. Incorporate the IVUS scores and the OCT scores to really determine which patients are going to be most likely to benefit from advanced lesion preparation. Match the tool to morphology. We didn't include this in this lecture, but we have shown previously when atherectomy is most likely to be beneficial, and that is when the lumen area is small at the maximum calcified site, so the atherectome interacts with the calcium. And then, of course, verify the endpoint. Look for calcium fracture or debulking. Use adequate balloon expansion as a surrogate for expansion, and this will help us strategize and optimize to get the optimal results in these severely calcified patients. Thank you so much.
See, that was really great. And I think that there are some comments coming in. So please, folks, keep submitting them in and we'll try to answer them. Maybe a simple one is that I think people get now with all the data that's been out there that you and others have contributed to that you need to do imaging. But I so commonly see at conferences and things like that, this issue exactly as you mentioned with the CT, the overly sensitive part of it. So tell us what's being done in the space now to try to hone in on image interpretation so that people don't just see calcium and just overreact to it in ways that, you end up pulling devices that you might not need. But on the other hand, like you don't want to get in a situation where you start struggling and then you could have just made the case much easier from the beginning. So, I mean, maybe what are your thoughts on this? How can we make this easier for people to do? Because I just see even like experienced operators on panels just getting it wrong.
No, so I think you're absolutely right. And there is a legitimate risk of over treatment here because we're getting so good at detecting calcium. You and I have seen in practice, even a fleck of calcium leads to an overreaction of very aggressive lesion preparation, which also may not be necessary. So I think we've made significant strides in intravascular imaging by making the calcium score for Calc 3.5 and for OCT the rule of threes. And we need the same thing for CT. We're working very hard on that. We have a fellow that's assigned to that from our almost 10,000 OCT patient database to help us identify what are the same or different risk factors on CT that we can give you a CT-based score. And on that note, it's really important to notice that I framed this right at the beginning that CT is oversensitive. It's this partial volume averaging is going to make calcium look much worse than it is. And I think two things are going to impact that in the near future. One is the use of AI on the CT based tools like HeartFlow, like Clearly, like Elucid, that are going to give you more detailed information for the calcium to help put it into perspective. And then second, I was going to say this is photon counting CT. We just published in JACC this month that you reduce partial volume averaging with direct effects on the measurements that determine how to lesion prep, arc thickness, and length by at least 30%. So the partial volume averaging isn't gone completely, but we're getting to the point at which you can interpret more accurately.
Oh, that's great. I think, let's let these questions keep coming in. Maybe we should jump to Dave's pre-recorded presentation on lithotripsy, because I think it'll get to some of these elements that people are asking about in terms of, what imaging parameters you want to choose to identify what to do, et cetera. So, I mean, it's great to have Dave on and telling us a little bit about, through a case, how you think through these cases and how you do them. So with that, I'll hand it over to you, Dave.
Thank you very much. Happy to be a part of this. I'm David Reisig from Banner University in Arizona. And I tried to pick the most provocative case that I could to really show the benefits of lithotripsy. And this has some acute and chronic facets to the case. It was a couple of years ago that we did this case. It's an 81-year-old female who was sent to me to evaluate what initially was described as an innocent murmur. She had progressive worsening of dyspnea and congestive heart failure. She had a history of COPD, hypertension, hypercholesterolemia, diabetes, and she had chronic kidney disease. You see her baseline creatinine and GFR. And in addition to her being symptomatic, I was asked to evaluate her for an innocent murmur. And on detailed questioning, it was very clear that this was not just simply a case of valvular heart disease, but also a case in which she had symptoms of progressive angina. You can see by echocardiography, no question, she has severe aortic stenosis. What we also saw in echocardiography is at least moderate severity aortic insufficiency. She hadn't had an echo several years earlier with an EF of 60%, and now there was a marked diminution in her systolic function, which we were able to really determine by using contrast echocardiography. No question about the severity of aortic stenosis, no question on echocardiography about the severity of LV dysfunction. We did the usual measurements in anticipation, and I promise this is not just a TAVR case. We did the usual measurements in anticipation of her being a TAVR. And there's some question about what do you do with patients with coronary disease? Do you even look at their coronaries in a patient like this? And we thought because she was having really a progressive angina and probably had an ischemic cardiomyopathy, and looking at the CT results, the pre-TAVR CT, that we should look at an angiogram. Here are her peripheral vessels, and this comes into play when you see the sum total of what this case involved. So we took her to the cardiac catheterization laboratory in anticipation of valve therapy, catheter-based valve therapy because of her age and overall frailty. And her diagnostic angiogram shows high-grade disease in the right coronary artery. And then this really, really calcified mess in the left main extending into the AD and the left main extending into the left circumflex. No question about the severity of disease. And you can see these calcium boulders in the proximal vessels, but you see, and I think Ziad set me up perfectly, you see calcified disease extending down the LAD. And so this is going to need advanced therapy. And we felt that this needed advanced therapy proximate to valve therapy. So in summary, we have an 81-year-old with an ischemic cardiomyopathy, 3 vessel in left main, CKD, COPD, and there was no enthusiasm on the part of surgeons, where historically this would have been the domain of the CV surgery. So in anticipation of TAVR, took her to the lab, and the first thing we did was to perform high-speed rotational atherectomy of the right coronary artery. We took on the right coronary artery first, uh, and after that, you can see our NC balloon fails to completely profile. And I think we did fairly aggressive rotational atherectomy. So because we couldn't get a balloon to profile, we then pulled out the IVL catheter and used a 3.0 by 12. And this was based on imaging. And in the interest of time, I won't show all of the imaging. And then after that, we were able to put an appropriately sized stent, a 4.0 stent, a 4.0 non-compliant balloon, and we got a really excellent result on the right. And so the intent now was to do a planned staged procedure. The one thing I didn't mention is each time we did passes with our rotational atherectomy device, she Brady down and she got hypotensive. In fact, there was a rather protracted amount of hypotension after each pass, which we were able to treat medically in the cath lab. Now, at that time, there was a spike in COVID. It was the most recent spike in COVID that we had in Arizona. And Arizona was also known during that same summer, the summer of 2023, to have a spike in West Nile virus cases. So our hospital was pretty much taken up by, cases of COVID in West Nile. So there was a statewide moratorium on non-urgent cases, and we weren't certain when we were going to be able to do this case. Within a week, she presented back to the ER, again hypotensive, in heart failure with positive troponins, and so she was taken immediately to the cardiac catheterization laboratory. And you can see on arrival to the cath lab what we faced. So I thought maybe the right coronary had acutely thrombosed, and you can see it didn't. The right coronary still looks about the same as it did before. So we felt that we needed to treat. She was having ongoing angina, a really high spike in her troponins. So we took her to the cath lab and performed intervention on her. So with everything that was going on, we felt that support would be prudent. We put a CP device in, loaded her with amio, shocked her back into a sinus rhythm, placed the Impella, and prepped her for coronary intervention. Used an appropriate wire to negotiate the high-grade disease in the LAD, as well as that aneurysm in the mid-segment. We used an Asahi Suho. And then we double wired, so we had wires both in the LAD and the circ. And because of so much hypotension, both during this event and in the previous intervention, we decided that we were going to try and do as much as we could with intravascular lithotripsy. So we used a 1.5/2.0 and then 2.5 balloon to get the 3.5 lithotripsy from left main down into the circ, and then did very much the same thing from the left main into the LAD, and got some really nice fractures with the lithotripsy. Did OCT guidance with this procedure, and then turned this into a two-stent, a multi-stent strategy, a DK crush, basically. And then in order to get our stents down the LAD, we, in addition to lithotripsy, we used a guide extension catheter. And really did a fair amount of multiple stents from main to AD, and then in the very proximal circ. You can see to the left our before picture with that big calcium nodule, and the post after lithotripsy plus stenting. We did no rotational atherectomy on this. And here's really a very beautiful view of what we were able to achieve with lithotripsy and stenting. We used OCT every step of the way to guide what we were doing. And at this point, she was hemodynamically improved, and we had no further complex ectopy. So we made the decision because there was a moratorium on elective cases just to do the TAVR in the same acute setting. So we pulled our CT device back, and this is the TAVR, and this really isn't the centerpiece of this case, but this is just for completeness sake. A lot of AI, both before and after we ballooned the lesion. And this is our final result, an aortic valve area of 2, mean gradient of single digit 5.9. And this patient did extremely well. She had marked hemodynamic improvement, electrical stabilization, excellent urine output. We were able to wean MCS immediately. We did not reinstitute it. We extubated her within the first 24 hours, and she was discharged. And this has been 3 years, and we continue to see her in our practice, and she's doing exceptionally well. I think the benefit of IVL in this case was that we didn't have to use rotational atherectomy because we had obvious concerns about that. And I only showed the TAVR because it was part of the overall strategy in the case.
Well, David, that's a phenomenal case. I mean, a super, super high risk. You're dealing with the extenuating circumstances of West Nile and resource utilization and all that, and pretty tremendous result. And I like that added the husband underwent TAVR after that. Maybe, we can get to some of these questions in the chat. Just a couple things. One is, when do you choose NC balloons, scoring balloons, IVL in terms of the algorithms and that kind of thing? And maybe we'll ask Robert first, maybe Z as well. How do you do it? Is it all imaging based? Is it kind of experiential based? Do you try with the other balloons first if there's less of a downside? Rob, what are your thoughts on that?
Yeah, I mean, I think Ziad said it earlier, really having some sort of algorithmic approach is important, whether you want to use one of the cities that he mentioned versus the Sky one. So I think it sort of depends on if you use intravascular imaging. You should be using intravascular imaging, but let's just say you're not. Then I think the tried and true sort of using the NC balloon, and if you can't get good expansion at nominal pressure, I think there's too many tools now with too much data to show that going to high pressure with various and sundries probably just, it isn't necessary anymore. We used to do it all the time, but I do think obviously if you don't have a 1-to-1 size balloon at NC with good expansion and multiple views, you've got to use something. And again, we can get into the data about whether that should be cutting balloon, IVL, et cetera, but certainly using something.
Z, any thoughts there?
Yeah, I agree. So, as you led a very important clinical trial, which showed that routine use of atherectomy in severely calcified lesions didn't lead to a significant benefit. What do we know from an evidence point of view? We know that intravascular imaging improves your outcomes, period. And so what is it that intravascular imaging can do that angiography can't? It's really what I mentioned, and that is identify morphology. Is it nodular? Is it deep? Is it concentric? Is it eccentric? And then you can really morph your tools towards that. I mean, in concentric calcium, as you know, really everything is very good, especially if you have superficial concentric calcium. I think a cutting balloon is an excellent choice in that. It's cost effective. It's going to create more than one fracture. It's going to give you a good outcome. But when you start to move into thick cap calcium, deep calcium, when you start to have nodular calcium, and I think Dave's case was, I mean, from where it started to where it went was simply, I mean, it's exceptional. You can't do that with just a balloon. It's impossible. So I think focusing on the morphometry is what's really going to help us choose the right tool. You just can't do this by the angio alone.
Yeah, I totally agree. And I mean, think that there was a question in there about what about the recent IVUS trials that didn't really show much of a benefit, IVUS chip and things like that. I mean, my take on these trials is that if, when you don't use imaging and then you start using imaging, you definitively change your practice overall. Once you start getting very accustomed to using imaging, then the marginal benefit is less because you're already sizing appropriately, you're already doing things like that. I think in calcified lesions is a different thing because you clearly can change what you do when you see what's going on with the imaging much more than you'll get with the angiogram alone. CT may help that a little bit. So my feeling is that I still try to use it routinely, especially in these cases, because there are times when I think for sure I'm going to have to rota and then or use IVL, and then I see that it's really a short segment of calcium and it's concentric and a balloon's going to work fine. There are other times when I think, well, the balloon's going to be fast, and then you realize that it's actually much different than you thought it was. And so why would you not use the catheters in that sense? I think there was a question about using NC balloon before IVL. Yeah, that's cost effective to do it, but just recognize sometimes that if you're struggling with the NC balloon and then you get a big dissection. I had a case just like this yesterday where, I went up high with an NC balloon in the one area that I thought, was borderline, but then distal to that, there was a big dissection. It was almost flow limiting. And then I had to struggle to get the IVL down. Thankfully, we had the Arrow, which is a new version of the IVL, which went down with no issues and it was fine. But it can be dicey sometimes. But that doesn't mean you should use IVL for every single case that you do. Dave, in that case, I was really interested. I thought that clearly after the experience with the RCA and the way she presented, you used support, but severe AS and that anatomy on the right, you didn't use support. So we have another session later on this, but how do you be judicious about stuff like that and also balancing into the complications as well as the cost of using hemodynamic support for a case like that?
It's funny, you and I showed a case at TCT a couple of years ago, which was eerily similar to this. And we had 10 people on the panel and we got 11 different answers on what do you do with AS and severely calcified disease and complex disease. The answer is, if you ask the expert, it's all over the place. I think from a very pragmatic standpoint, I prefer not to be trying to get support in once the patient is crashing. So based on our experience with the right coronary artery, I did not want to be crossing, we were going to be doing left main AD circ and at the beginning of the case, who knows what therapy we were going to employ before we went to IVL. The point is, I think you're justified in putting your support in ahead of time, especially in patients with aortic stenosis. They are prone just on the aortic stenosis alone to subendocardial ischemia. But this patient was going to get ischemic no matter what we did because of the extent of disease, severity of disease, and the extent of what we needed to do. So I think an upfront strategy was more than prudent.
Oh, 100%.
Yeah,
I actually meant more for the RCA to start off with. But yeah, go ahead.
Yeah,
Robert,
I thought. Oh, Rob, go ahead. I'm sorry.
Oh, I just there's been a lot to do about this topic since the chip Thesis 3 came out not too long ago from our UK friends, and it's a big to do about is this going to change practice patterns both within the country, obviously in the National Health Service, and then a non-constrained country like the United States. Is there parity there? What does that mean? And when you run service lines and things like that, you do have to think about, does this change clinical practice because it affects the business model and sort of how you do lots of different things on your spreadsheet. And so, one does have to really think about that. And I think what we realized is that there's still going to be cases that you eyeball and you just say, whether it's to Dave's point, this person had severe AS, they had hemodynamic instability, they have severe left main. I know what the trial showed, but I still feel like I need to use an Impella here. And there's still going to be those cases. And what that means is that we just simply haven't identified the covariates that lead one to know whether they need to use the device or not. At least that's been my take, is that there's still some things out there that we just haven't identified that we need to put into our clinical models to know. And so I think very much in this case, it's going to be a gut check. What we have to as a community move away from is having a very experienced operator like Dave who can go into a situation and identify that and know, to something that we can extrapolate to everyone else, right? Because those gut checks, unfortunately, are going to become less and less as our numbers of procedures go down, and as our experienced operators end up turning over to the current generation. So we have to get that sorted.
You know, Ajay, it's interesting. I have done a number of cases with both Rob and with Ziad in the cath lab, and I've watched you show cases from the podium, and there is the science of medicine, which is of exceptional importance, but there's also the art of medicine, and the science doesn't always answer all of the questions when we are confronted with a very sick patient like this with multiple medical problems. I mean, you're talking about, you know, kidney disease and LV dysfunction and advanced coronary disease and advanced aortic stenosis. And these are not the patients that we're capturing routinely in clinical trials. And that's where the art of medicine, the experience of medicine always comes in.
No, 100% agree. And you also have to be circumspect too. I fully agree with you on all those things. And unfortunately, not too long ago, I had a case where, I put in support for the exact same reason, and there was a vascular issue that happened. So I think the key thing is you always have to be humble. You always have to recognize that you just do your best, and you have to think. And that's, I think, what the point of the calcium session is too, is it's just don't use one device. Think about what you're doing, react to the data you get from the imaging, and based upon that, then modify what you're going to do, and always remain circumspect about everything, and don't use an N of one argument to justify your clinical practice as a whole, because random stuff always happens to everybody. So with that, let's go to Rob. Rob's got a great case as well, and then we'll get back to some of these other questions that are in the chat. But Rob, take it away.
All right. Well, again, thank you to Ajay and this great group of individuals that I've had the opportunity and humble opportunity to work with a lot over the years. And so great to be with y'all today. So I was asked to spend some time talking about sort of a rotacut strategy, what that looks like. We'll set a little bit of precedence, and then we'll talk about a case. Looks like that works great. These are my disclosures, which really boil down to is that I work with a couple of companies on a routine basis that make calcium modification tools, and then I'm the national PI for the Forward CAD study that's ongoing with calcium modification. So the reason that we talk about this, again, just to set a little bit of the baseline, is we've seen this slide time and time again, but it's really moved. Calcium modification has moved from very niche stuff when I first started to the universities to over a third of our patients have moderate to severe calcium, and so it's something we all have to deal with. And so it's a lecture that we all have to listen to, and we all have to get sorted. It's not something that, again, we can defer to others. There's a lot of great stuff out there. When I first started this, there wasn't a lot of things out there. There was the various forms of atherectomy, which have been around for some time. Orbital started about the time that I started my career. There were some older calcium modification balloons, some specialty balloons, but now there's been a proliferation. And there's even more than's even on this screen, because there's various ones that try to be sort of IVL-ish. There's various types of modification balloons. And then obviously with the advent of IVL, we really saw the space start to bloom. As mentioned, there's a lot of different calcium modification algorithms. I never have thought about the city approach that Ziad mentioned. I guess there's tubes and subways and all sorts of things, but I was lucky enough a couple of years ago to make some iterations on previous algorithms we had put out, and then try and put out a SCI consensus one. And with the rotacut strategy, we're really talking about the unable to deliver. There's still some roles for atherectomy and wire and non-wire cross gear won't go, but they're starting to become less now that IVL has more shocks. We've got more specialty balloons. There's more data to guide that. So atherectomy will continue to really shift towards that wire cross gear won't go strategy. Although again, that's going to be potentially changing too. Obviously, I do sort of have to mention this as the national PI Forward CAD study looking at an IVL solution with an emitter at the front end of the catheter meant to get into tight spaces and heavily calcified vessels. And we'll be really excited to share this data with some of the other folks at TCT this year. Ajay. Anyway, so looking at rotacut as vessel prep for calcified lesions specifically, what we're not talking about is atherectomy versus balloons. I think when we talk about all this nomenclature, what I want to make sure we know what we're not talking about and what we are talking about. So this is a patient level pooled analysis from Prepare Calc and ISAR Calc. And what it showed was that there really wasn't that much of a difference in atherectomy versus specialty balloons for very calcified lesions. The only caveat to that was that you had to bail out of balloon-based strategies to atherectomy more often than atherectomy. It wasn't a significant percentage, but it did occur, which makes sense, right? There's just going to be areas where you can't cross with a balloon. And again, this goes back to a lot of atherectomy is going to be towards that wire cross. I just can't get gear to kind of go across that we spoke about in the algorithm earlier. What we are talking about, however, is really using a combination of rotational atherectomy plus a cutting balloon versus rotational atherectomy and a conventional balloon, meaning typically NC balloons in this scenario for heavily calcified vessels. So there was an interesting trial several years back that did show, in fact, that you could reduce your MACE really driven by target lesion revasc when you used a cutting balloon after rotational atherectomy compared to a conventional balloon. So there's a signal for decrease here in your MACE by your TLR. So that's kind of interesting. But there was no difference in periprocedural complication rates. And one of the biggest things when we look at calcium modification strategies that we have to zero in on, sometimes even potentially more so than our success rates, are what are the complication rates? Because we know that these are vessels that have higher MACE rates compared to non-calcified vessels. So you always have to ensure that those are either a primary or at least a secondary endpoint and that you're powered enough to get there. So we have a second study, again, following on the steps of that, showing a retrospective propensity matched analysis of rotacut versus, again, rota and conventional balloons. And again, we see a very similar signal of decreased rates of TVR. So again, this matches what we saw several years back. So again, very interesting. No difference in MACE rates between these groups. So then what we see is a meta-analysis. Again, this is all building towards something, right? This is all the data for the rotacut study we'll look at in a minute. And again, we do see that decrease in MACE, again, primarily driven by target lesion revascularization. So these are all positive signals that one would look at and make the case for a large scale, a prospective study, the rotacut randomized control trial that did come out, again, looking at rotational atherectomy followed by cutting balloon versus non. And what we see here is really no significant difference in any of the primary incomes. We really didn't see too much in terms of final MSA. Fractures, what does that mean? Again, the things we know affect outcomes, there really was no difference. And notably, there was no difference in complications, which I do think is important because there may be scenarios where the NC balloon just does, I don't know the way to say this without a bad pun, but NC balloons just don't cut it and one has to switch to a cutting balloon. So it doesn't mean that by this study that you should never do it. It means that when you do it, however, there's not going to be an increased risk compared to just NC balloons below. So kind of summarizing what the data really shows before we jump to a case is that the older data did show a promise in reduction in long-term MACE driven primarily by the decrease in target vessel revascularization when you add a cutting balloon to rotational atherectomy compared to a non-cutting balloon. But the newer randomized data didn't really seem to show very much difference other than some increased cracks on intravascular imaging compared to a non-cutting balloon strategy after rotational atherectomy, although again, very similar safety profiles, which is important. Thus, it works just as well, a cutting balloon versus a non-cutting balloon strategy, but it means that if you have to use a cutting balloon afterwards, you're not increasing the risk for the patient, which again is really important information for those of us that take care of heavily calcified lesions on a routine basis, which again is most of us. So now we're going to go to a case to just show like when you do need to go to that strategy, what does it actually look like? So this is a case that was referred to me from somebody else around who, it was an LAD CTO they had attempted and they did integrated wire escalation, got subintimal, and it got referred to me so that I could do ADR versus go retrograde here. And so for me, this is actually a nice little ADR case where I kind of was going to get subintimal, just follow exactly what they did and just switch out for a Stingray and hopefully perform ADR. So we got set up here. The patient had some radial issues from this. This was a 7 French guide and things apparently didn't go well with that site afterwards. So we had to go bifemoral. We did end up waiting a little bit because we like these areas to heal. before we necessarily go tack them back up unless there's a clinical reason not to. So again, we've got the setup here, heavily calcified, relatively short lesion. Anybody that does enough CTO PCI knows that these are sometimes terrible lesions because the heavy calcium like that typically does push you out. But again, we know our strategy, we're ready to roll. Unfortunately, 135 Corsair Pro XS goes in, and the Hornet 14, we wire escalate. I kept hitting the hard proximal cap, and I was like, just deflect, just get something. Please help me out here. And the Hornet 14, unfortunately, goes true to true, which again, some people would say, well, that's really good. Not really, because I don't really want to deal with the calcium. I'd actually just rather go around it. But in this case, it does what it is. So you can see in multiple views, the Hornet 14 is down, and so fine, I guess we'll move on. We really struggle getting the microcatheter across in this case, and it's not a surprise why. That's a heavily calcified cap, and you can see the 1.5 and 2.0 balloons just look like trash. So that's not going to be a winning strategy. I don't want to spend my time balloon after balloon after balloon. So we just switch out to a 1.5 burr. I don't traditionally save those floor stirs because we wrote enough that I guess I don't really think too much about it. And afterwards, we switch out. But I tell you what, after that 1.5 burr, the 3.0 balloon, because the burr really struggled to get around that bend to drop into the distal LAD. It's just not ready for IVUS yet. And so we want to balloon it up a little bit more. But man, that NC still balloon still looks bad, right? Even despite the rotational atherectomy. So we're going to need something else. IVUS shows thick concentric and eccentric calcium. Not a surprise. Again, a big chalk pile before we started, even after atherectomy, still doesn't look good. Based on some recent studies put out at TCT last year, decided to go with a 3.5 Wolverine balloon here. You can see really good expansion of a 1-to-1, of a 0.5 decrease size down cutting balloon here at 18 atmospheres. And then afterwards, what's pretty cool is you can actually sometimes see, even on IVUS, I know it's not OCT, but even on high def IVUS, you can sometimes see the little cut, the little cuts in the calcium as you come through. And what it just shows that the balloon really expands concentrically as opposed to eccentrically, which many other balloons often do in these types of calcium. So here is an NC balloon after that. So we're really, so I'd had to downsize 0.5 up here because it's a 4.0. Down here, I'm able to kind of get to more of a 3.5 NC balloon to really spread those cracks further out. And what's pretty cool is this is a stent-like result. Like this looks pretty good. And what I want you to notice is all of these tiny vessels. What we know about target lesion failure is it's based off epicardial flow. And all of these vessels are so important in epicardial flow, but a lot of them have plaque shifts. They're too small to really rescue per se, all these little septal guys, but we know they're important for vessels staying open. And we know that calcified vessels have a particularly difficult time staying open at times, even with good vessel prep, because there's encroachment of the calcium back into the lumen. So in this case, again, I realize that this probably isn't everybody's go-to here, but I actually used a DCB in this case because I had a stent-like result with really good plaque modification. So you can see I've got a long DCB in here. And again, this is a lot of my practice. Over 60% of my PCIs and de novo lesions involve DCBs. There's a lot of retrospective analyses at this point on calcified lesions and how DCBs could potentially be more beneficial than stents. Again, I'm happy for people to tell me I'm wrong, but this is just what I've been doing for a couple of years now in these kinds of situations. You can see the post DCB runs here look really good with preservation of all of those little branches. So it felt really good for her. And she actually ended up coming back. This was a case just a few weeks ago, but she actually came back a few days ago and had complete resolution of her symptoms. So felt really good about that. So in conclusion, these calcified lesions are common. We just got to say it. They can be difficult to treat. They're even more difficult to treat and get optimal outcomes without MACE. And that's a real thing that we all live with. There are algorithms. They really help. I think that having an algorithm approach will allow you to have some sanity about how you choose what and when. But there's evolving tech, and we have to be open to the fact that these are going to continue to evolve and continue to do education, things like this together so that we can all continue to evolve as a community. The rotacut strategy works just as well as rota NC balloon, but it means that if you have to use it as a ballot, it doesn't increase procedural risk. Thanks very much.
That was great. Great summary of the data. Also, great case too. One thing that I think really should be mentioned, which you did a little bit, was if you're going to use either Wolverine or an OPN balloon in calcified lesions, in general, the recommendation is going to be downsize by half and then go up to higher pressure. And that's a little bit different from what we used to do previously. And I think in that rotacut study, it may be one of the reasons why the study was the way it was. There could be other things too, but just remember that and don't make the mistake of going 1-to-1 and then going up high with that, because you can cause some complications that are irreversible under those circumstances. Dave, I think you had some thoughts on the historical view of rotacuts. So tell us a little bit about that.
Yeah, exactly. I was the first proctor in the United States for what was called the Barrett surgical cutting balloon when IVT owned it prior to the Boston purchase. And during the CAPAS trial and other early clinical experience, it was an absolute contraindication to do rotational atherectomy married to a cutting balloon, but it was in the absence of any data whatsoever. And I'm really glad that you have talked about that to clear that up, Rob. That's a really nice analysis of where we are. But back in the day, this was 1994, it was absolutely contraindicated, but no data to support that contraindication.
Yeah, and I think the other thing too to remember is that if you do a good job with atherectomy, there are some data, at least from Shortcut, that shows that in the cohort that had atherectomy, cutting balloon did really, really well with comparable results in terms of imaging, at least to that of IVL. But remember, as I think Rob stated very well, it's not just the MSA and it's not just the MACE that happens afterwards. It's also, is the procedure safe and can you do it in that way? And I think that some of the larger data sets will start to get at this and we'll start understanding a little bit more about comparative safety and efficacy. There are a couple questions in there about different devices. Or they need two devices? Are they better? We don't have a lot of comparative data on things like this, especially new entrants. So that's one of the reasons why we need to generate some of that as well. That's whether that's one of the questions was orbital versus rota. One of the questions was bolt versus shockwave. All these things that with these new devices that are out there, I think the field is open for these types of comparative tests to see, and they may be no differences or there may be differences. We'll have to see. And obviously there's ease of use differences as well that can happen with these as well. What about maybe Z, I'll ask you this. There's a question about further modification, adding risk rather than adding more value. And maybe you want to talk a little about this issue of nodules and 1-to-1 sizing, and is perfection the enemy of what the patient needs in terms of getting the job done in some of these tougher cases?
Yeah, great question. So, I think that in general, you need one tool. Now, if you pick your tool appropriately, for the most part, you can get adequate lesion preparation and get a good outcome. There's a few nuances to that. We have to reteach people how to use the angiogram to interpret whether you've had effective lesion preparation. Because you were mentioning this earlier too, that, people ask this question, well, can I just use an NC balloon? So the problem is if you just use an undersized NC balloon, it's always going to look good. And so you need an appropriately sized NC balloon and then look how the balloon is behaving on that calcium. Is the wire centralized? Is there equal amounts of contrast on both sides of the balloon? That gives you an idea of compliance without doing intravascular imaging. And even when you do intravascular imaging, we showed that you miss 50% of the fractures by OCT, and we just presented at PCR, you miss 60% of the fractures by IVUS. That's no small amount. So I think the nuance here of using multiple tools is when you're not getting those either imaging or angiographic predictors of success. And that's the time to upscale and maybe consider using additional tools, not just, say, okay, good enough, I'm done, and I'm just going to stick it under expanded stent.
Yeah, I think that's such an important point because you do need to use all these things together. And, just another case yesterday where it was a balloon uncrossable lesion. We actually, maybe if we have the forward device soon, and Rob, thanks, we'd love looking forward to seeing that at TCT, but maybe we would have used that. But in this case, we wedged a microcatheter and wire down distally, did rota, and actually NC balloons expanded really well. But we looked in both views to make sure that that was the case. And then it was a little bit nodular. We put the stent in, reconfirmed that the area was adequate with expansion, and then didn't go crazy with, dilating it to 4 or 5 and that kind of thing, because that's how you push the nodule right through the side of the vessel. And yeah, you'll get better expansion, but you also may get a perforation. So I think these lesions, we all know they're harder to treat, but you got to really be meticulous about how the way you do the cases, and just work step by step, and react to the data in real time. Let's go on to Margaret's talk, because I want to get that done, and then we'll have definitely time for discussion at the end. And she's going to talk to us a little about what we can look forward to in the future and strategies that are fracture-based for treatment of calcium. So let's go to that, and then we'll come back to questions.
So hi, I'm Margaret McIntyre from Columbia University Medical Center in New York. I'm going to talk to you about the future directions in calcium modification. If we start by looking at the current landscape of calcium modification here in the USA, this is some data published in 2023. And what it shows you is that from 2018 to 2022, over that 4-year period, the use of calcium modification increased from 8 to 16%, so doubled. And really notably, after the approval of IVL in 2021, you see that that became the dominant device used for calcium modification in the US, accounting for over 6% of cases back in 2022. And this trend has continued to increase. But despite now us having an array of devices that we can use for calcium modification, there are still some persistent limitations. So some of the technology requires technical skill acquisition to be able to use it. Some of the devices are associated with plaque embolization, particularly atherectomy. Some of the balloon-based technologies have problems with crossing profiles. And there's also some concern about the risk of coronary injury with some of the technologies more than others. So the focus of the next generation of devices really has been moving towards ease of use, improved deliverability, and attempts to minimize injury and procedural risk. And this has also involved some technical innovations, including the use of laser as an energy source, optic acoustic wave systems, multi-emitters, and contact mechanical force vectoring. So I want to take you through some of the newer technologies that some of the devices which are already currently commercially available in the US, but also some of the devices that are on the horizon. So we're going to start with the Shockwave C2 Plus Aero device. So Shockwave is currently the only commercially available IVL system in the USA, and they've gone through now a couple of iterations of the technology to try and improve its usability. So the C2 Plus Aero, with this new iteration of the device, what they've done is managed to improve the flexibility of the catheter and the marker bands. They've added a new hydrophilic tapered tip, which improves crossability and deliverability. They've also adjusted the positioning of the emitters with the most distal emitter closer to the tip, allowing you to deliver therapy more distally and difficult to cross lesions. And they've also managed to reduce the pause time between the delivery of cycles of therapy. Now, often when we get iterations of devices, when you actually use them in clinical practice, we don't often see a real world change. But I have to say, having used this device now on many occasions, it really does demonstrate improved crossability and deliverability compared to the previous version of this technology. Shockwave have also tried to tackle the issue of balloon uncrossable lesions with the Javelin device. So this is a catheter that has an IVL window at the tip, which is filled with fluid, and there's a single emitter. And as you see from this animation, the single emitter is trying to deploy therapy both radially, but also in a slightly forward direction to allow crossing difficult channels. Now, the Javelin device has just completed the forward CAD trial, and we're waiting for the results of that in the coronary space. The commercially available device is currently in use in the peripheral space. couple other technologies to mention that are on the horizon, the fast-wave coronary IVL system. So the focus of this device is to deliver therapy quickly in a 360 circumferential manner. And also there's been a big focus on this device and improved crossability and trackability. It's anticipated that this device will go through its IDE trial commencing later in 2026. Another technology that's of interest is the Hertz Contacts IVL system. So unlike the other lithotripsy systems, there's no energy source with this device. It uses mechanical force vectoring delivered through rows of microscopic stainless steel hemispheres like you see in this illustration, creating highly localized focal points of stress. So this device now has a CE mark in Europe after the Pinnacle trial, but as yet unavailable commercially in the US. One other device to mention is the Abbott IVL system. Despite actually personal efforts to reach out for illustrations and further information about that device, which has recently been studied in the Tectonic trial, there's actually very little technical information available that I can share with you today. I want to spend most of the rest of the talk talking about the Seismic 4CE device, because this is the device that most recently has produced evidence in the IVL space with a late-breaking trial at EuroPCR just last month. So this is a laser and optics-based IVL device. So laser travels down optical fibers and it hits tungsten emitter and generates a laser spark. That laser spark then creates an acoustic pressure wave. The plasma forms a rapidly expanding collapsing vapor bubble. And you see from the illustrations here that there's these alternating pressure waves, and the device has quad emitters, so has 4 emitters around its circumference at 2 emitter stations. The idea of that being to try and deliver more circumferential therapy. So in the fracture IDE trial that was presented recently, there was 420 patients with severe de novo coronary calcified lesions enrolled across the USA and Europe. You'll see there was co-primary endpoints: safety, freedom from 30-day MACE, and effectiveness, procedural success. The key inclusion and exclusion criteria are given here. What you'll see when you look at all these IVL-based trials is they're largely modeled on the design of the Disrupt trials, which was the IDE trial for the original Shockwave device. So what you see is severe calcified de novo lesions defined either angiographically with radiopacities on both sides of the vessel wall over 15 millimeters, or an arc of calcium of greater than 270 on IVUS or OCT. Vessels had to be 2.5 to 4, lesion length less than 40, and the stenosis had to be greater than 70 or have an MLA of less than 4 on imaging. And you can see there the usual exclusion criteria for these types of trials. Interesting things with regards to lesion and procedural characteristics. So almost 60% of the lesions were in the LED. You'll see the lengths of calcium were long, a mean of 38 millimeters. Say about 30% of the cases were bifurcations. In terms of the procedural data, the very high use of imaging, 88%. Roughly 1 catheter was used per procedure, and the mean number of pulses delivered was 220, with this device having the capability of 320 pulses in total. So if we start by looking at the primary safety endpoint, so the statistics were based on performance goals that were derived from a meta-analysis of Disrupt CAD3 and Orbit 2 of the Shockwave IVL system and orbital atherectomy. So the performance goal was set at 86.2% for safety of 30 days freedom from MACE, and you'll see that the outcome from the trial was 93.3%, with the lower bound of the confidence interval at 90.8%, so well above the performance goal. And if you look at the table underneath, you'll see almost all of those events were periprocedural MIs, according to the protocol definition, which was simply a CKMB of greater than 3 times the upper limit of normal. We went on to look at Fourth Universal and SCAI definition, where clinical or EKG factors were introduced. The incidence was significantly lower. When we look at the effectiveness endpoint of procedural success, you'll see that was achieved in 93.7%. Again, the performance goal was 85.8%, with a lower bound of the confidence interval way above that at 91.4%. If you look at the table below, you'll see that successful stent delivery occurred in 100% of cases, less than 50% residual stenosis in 100%. And again, this endpoint at 93.7% was all driven by those procedural MIs according to the protocol definition. Angiographic, there was an incremental increase in MLD after IVL and after final stenting. And very reassuringly, you see on the table on the left that the instance of complications was extremely low at 0.2% with only one type D dissection. There was a core lab sub-study within the trial, which confirmed that this was indeed severe calcium with a mean arc of calcium of 272. There was 27% of calcium nodules. Calcium was thick at 0.9 millimeters. An IVL, post-IVL fracture could be seen on OCT in 67%, and the final MSA was 6.5, with stent expansion at 94.2%. So the conclusion of the analysis of the fracture ID was that this novel optic and laser-based IVL system was safe and effective in the treatment of severely calcified de novo coronary lesions. The device was deliverable, associated with high procedural success and low complication rates. Stepping back and looking more generally at the future direction of calcium modification, I think that we're going to see the continued development of devices specifically focused on improving technical accessibility for all operators, improved deliverability with predictable and consistent efficacy, and improved procedural safety. I think there's still some unresolved issues that we need to further iterate the technology to address. I think we still have an issue with the truly uncrossable lesion. Although rotational atherectomy is often the solution in this situation, there are occasionally cases where you can get an advanced wire across a lesion that can't follow it with a microcatheter or deliver an atherectomy wire. So I think we still need to tackle this, and we'll wait the result of forward CAD, but I think there will be space for further iterations of devices to help us tackle that problem. I think we still need to continue our focus on nodular calcium, discuss and debate in which situations we need to reduce the volume of the calcium versus increasing vessel compliance to be able to absorb that protrusive calcium back into the vessel wall, or situations where our aim is actually to destroy the calcium nodule, particularly in the situation where you're dealing with an eruptive nodule, and we can discuss the kind of malignancy of that particular morphology and how best to manage that. Lastly, I think we need to gather further evidence on device efficacy across all these different calcium morphologies. Thank you. With that, I'm going to hand back to Ajay and the panel in the studio to further discuss this interesting topic. Thanks.
Well, that was an awesome talk and seamless transition back to us. And it leaves us about 5 minutes for discussion. You know, one thing that struck me a little bit is that there's some questions about, are we seeing shifts in strategies or more accessibility and that sort of thing. I think it's super exciting to be able to get newer and newer tools and also focusing on fractures and focusing on mechanistically what we need to do. There's some cadaver studies that have been out, and Ziad, you were part of that, you know, really start honing in on what exactly we're doing. One thing that has to be asked for a U.S. audience, though, is issues of cost. I couldn't, Dave, your case was a Hail Mary save, unbelievable, but I couldn't help think about, you know,
spent a lot of money
administration might say. About it. So you know, and Ziad, you're a lab director. David, you deal with these issues too. Have these things come to be manifest in your lab? Rob, you talked about that amazing demonstration, DCB only use after what you did, but you know, I can't imagine 60% DCB use. The administration is too happy about that, or maybe they need some justification. So how do we develop the evidence to help that? And do you see this in your daily practice at all? Maybe Dave, start with you, then Z.
I think these cases need to be, the one I showed, needs to be the exception rather than the rule. I think we take these on weighing carefully everything about the patient, but you couldn't be more right about, if you do a lot of these and they're not well chosen, well thought out cases, you're going to be looking at real financial problems with your cath. I think they need to be the exception rather than the rule.
Z, how do you deal with this?
So first, of course, it's important to understand that there's just one pie, right? So we can cut the pie in as many ways as we want, but out of that, you've got to pay for renal denervation, tricuspid replacement, severe calcified coronary, laser, prostate resection. It's one pie. And so there's not any more money. So what we're really doing is shifting money around, including for DCBs. And so, obviously, on the top of the priority list is what is best for the patient. But very quickly, there becomes some area of equipoise, right? Where there isn't very clear ideas of greater efficacy. And so, in that case, I think, we need to understand that there are costs and we should be trying to be cost effective. So what we did in our lab, which is one of the busiest in the country, is we implemented rules for when you could use what. And some of those actually are unique in the sense because we're also a very high volume research center. And we tell the patients that, if we can involve them in clinical trials, that some of these costs can be covered and it takes some of the handcuffs off financially. The second is we also tell our investigators that that's an incentive for us to enroll patients in clinical trials. And third, when there isn't clear-cut benefit of one device versus another, we try to use the cheaper alternative. It also behoves us as interventionalists, lab directors, senior physicians to teach everybody about the cost, because I think there's been this sort of faux pas about talking about money in the cath lab. And when I got to St. Francis and I learned the cost of everything, people were asking me like, why do you know that? Right? How do you know that this, this wire costs $40 and this one costs $80? But what's also amazing is when you teach the physicians, they actually quickly become fiscally responsible for the most part. And that's important because if you don't know how much something costs, you don't care. But as soon as you know that it's going to be cost, something's going to cost, and then look at that more holistically from the cath lab's point of view, I think that can make a very big difference.
Maybe Rob will give you an opportunity as well. You're a lab director too. And so how did you navigate that DCB thing that you talked about, or just in general, any other thoughts? This is a great discussion because we don't often talk about stuff like this, but it's really practical and important.
Yeah. I mean, there's layers, right? So there's patient cost, institutional cost, and then cost to the broader community, meaning to Ziad's point, one big pot. So there's like levels that one has to think through. So for a lot of cases, which is tough, we don't have great answers for, unfortunately, a lot of the kinds of cases that I treat, meaning really long lesions with a lot of negative remodeling downstream, which in the past we've either left alone and had people come back because they had downstream disease that wasn't treated well, or they come back because we laid a lot of pipe down the coronary and the vessel grew with positive remodeling, as we know occurs, and then there's a stent mismatch, et cetera. And so part of it is driven by need in some stances where we put a patient through a high risk scenario, and there is a belief pattern that continues to need clinical trials and studies to put real data behind it, that we want to ensure that if we put somebody in a procedure with a MACE rate of 5 to 7%, that we optimize the probability of them not coming back. So there's that piece. There's also the piece of the TPT payments that actually don't really care if it's ISR or de novo, and being able to navigate that, which we often do. So obviously using more than one DCB is off limits. Using DCBs for inpatients is really problematic, right? Because the other side of the coin is not there. And so there's levels to that, which I fully recognize. I think the challenge for me is that having the opportunity to work overseas, as I often get to, and seeing what my colleagues have been doing for a long time and getting really good results in a lot of the international data, it makes it a challenge to not deploy the therapies that I believe will lead to a better result. But to everybody's point, there's got to be more clinical data, and I fully realize that there are times where I'm probably operating off the cusp.
Well, look, I think the most important thing is to be flexible because there are many tools out there. And if we can use all those tools in a way that we know what the risks and benefits are for the patient, that's how we can apply these therapies most effectively. If you're only a one-trick pony, you're not going to be able to do anything else. And I think that's going to be to your detriment in the long run. So just want to thank all of you. It was a phenomenal session, starting with the requirement and need for imaging, going through the various technologies, mainly going through the thought processes of how you can do these really, really tough cases. Great discussion along the way, and we'll now pivot to the next session. But really, once again, thanks for all your contributions. Enjoy the rest of your Saturdays.